A pediatric CIN means that you have an entire donor-led infrastructure behind you that's got your back. And because it's led by pediatricians, it has quality measures and goals designed for kids. And because all these doctors are coming together around quality and decreasing costs and unnecessary utilization, we believe that payers will be excited about working with them. See, they're facing their own pressures to control healthcare costs. If we can reduce the overall costs of care while improving quality, payers will be more inclined to share the savings with physicians that can demonstrate that value. And that's a win-win situation for physicians, payors, and patients. But in today's world, where a doctor sees 30, 40, 50 patients in a day and gets paid for each of those encounters, it's hard to imagine how a CIN that is focused on quality rather than volumes would actually work. In today's world, it's hard for a physician to feel like there is ever enough time to spend time with your patients and their parents, complete all the patient charts, stay on top of the latest research and care guidelines, coordinate the care for kids with more complex needs. And the staff? They're busy, trying to schedule a patient with a specialist who's got a 3-month waiting list, checking on families, making sure they show up to their next appointment, pulling charts and tracking down information when payers deny claims. It's downright exhausting. On top of that, payers seem to keep looking for new ways to cut payments to providers to offset rising healthcare costs. And retail clinics are targeting kids and teens for primary care services without the training or expertise to provide high-quality care. So what can a CIN provide that can change all that and bring doctors back to doing what they love to do most, taking care of kids? In a pediatric CIN, primary care and specialist physicians would collaborate to focus on common childhood issues where the members of the CIN could make the most impact, such as asthma, childhood obesity, immunizations, or behavioral issues. CIN specialists and primary care physicians collaborate, reviewing the latest evidence and developing care protocols. They then give other CIN physicians the tools and resources that make it easy to integrate the protocols into their practice. This improves access to specialists by making sure kids are seeing the right doctor at the right time. And because the CIN has a software tool that helps with population health management, the CIN can monitor outcomes. And by being able to demonstrate that CIN members are providing top-notch care and preventing things like unnecessary ED visits, they can work with the payers to share savings through contracts that reward performance. But with all those kids being managed in primary care, sounds like more work, not less, right? Not really. By using the support of advanced practitioners and the CIN's care management resources, doctors can better address groups of kids with common chronic illnesses. This gives them more time to devote to one-on-one time with the kids that need it and consult with specialists when necessary. And if there's an issue from one of the payers, the physician now has the CIN that can provide the right data and work with the practice to challenge any claims denials. But why would payers want to pay physicians more for providing care? Well, right now, they contract with that individual practice. With a CIN, they would have an entire community of pediatric physicians who have come together to improve quality, increase efficiency, and reduce costs, and can prove it. That means less downstream payouts for payers, less kids with asthma in the ED, fewer kids developing preventable conditions such as type 2 diabetes. That's a relief to payers, employers, and a mom and dad who are paying more and more out of pocket for healthcare. But the ones who benefit the most from this are the kids. And that's the most important reason.